Hello, hello. How lovely to have you with us.
Thank you very much.
All the way from Philadelphia.
All the way from Philadelphia, but really Madrid. I was born in Philadelphia, but I'm based in Madrid. Yeah.
Right, we sorted that out now. So, Seonaid, tell us a bit about you.
Sure. So I am on the H2O Patient Advisory Board for type 1 diabetes in Spain. I'll go through my background that I've brought for today. So I was diagnosed with type 1 diabetes in 1998, which is almost 25 years living with chronic illness, hence the title, A Quarter Century of Diabetes. In that time, I've seen how technology has evolved and changed to make management of my condition easier. And just for a bit of context, I'm not sure how much knowledge the audience has in general about what life with type 1 diabetes entails. My body doesn't produce insulin. So what's insulin? Well, it's this wonderful little hormone that most people don't know exists until something stops working with it. So our bodies need energy to survive. We get that energy from our food sources. But in order to process that energy, which namely comes from glucose, we need insulin. So insulin is like the key that opens the door to your cells so that you can receive that energy, remain happy, healthy, upright, the nice, beautiful flat line of blood sugars. That's how it works when it works well. In my body, since I don't produce insulin, my management consists of using an insulin pump to deliver insulin as I need it throughout the day, and using a continuous glucose monitor to make sure that my levels stay within a healthy range for as many hours a day as possible and with as little variability as possible as well. And it might sound simple enough, like, oh, okay, check your sugars and take your insulin and everything's great, until you realize the number of factors that can affect not only your blood sugar levels, but also your sensitivity to insulin. So everything from stress to speaking on stage at an event can affect my blood sugar level. Activity, lack of activity, routine, travel, normal people illnesses like colds and flus, all of that can really affect your ability to manage this condition. And then on top of that, broader issues like the access that you have to healthcare, the access you have to education, to get the health literacy you need to take care of yourself. So there's a lot of factors that come into play. And I always kind of describe type 1 diabetes as living in a sort of perpetual balancing act for that reason. I think given everything I've just said, it's a condition that requires a tremendous amount of self-management, self-awareness, and motivation on the parts of patients. And luckily, the tools to do this have come quite a long way in an arguably short amount of time. Just 100 years ago, we got insulin, the first patient treated with insulin. So in other words, 100 years ago, diabetes was a death sentence. I wouldn't have ever made it to this stage. 50 years ago, I might have been on this stage, but with complications because of a lack of knowledge about how to treat the condition and tools to do so. And in the just 25 years that I've lived with type 1, I wanted to demonstrate how much data tracking for my own condition has changed over the years. So when I was first diagnosed, I had this glucometer machine that took a whopping 60 seconds to give me a result and tell me what my blood sugar was. And at the time I was a child, so my mom would take the pen and paper and fill out the paper logs, write any comments about the food I'd eaten, anything that might have been relevant. And we'd discuss that with my doctor every couple of months. And this is what my data tracking looks like nowadays. I have an insulin pump. I have my continuous glucose monitor that I can scan and get a result immediately. And from that data, I can download it and see the trends in my blood sugar over long periods of time. I can get a full picture of 24 hours a day, exactly what's happening in my body. And as you can imagine, that's made my self-management 100 times easier. But not only that, it's made the the appointments that I have with my medical professionals more accurate, more productive, and it's allowed them to give me guidance that they simply couldn't when I was first diagnosed.
And do you share that with your physician? So do they share that? What I mean is, do you have to take it into them, or do they receive it via some kind of upload?
They receive it automatically, so they have access to, I have to do the work of uploading the data as often as I can, but they'll receive it automatically at the hospital.
So they can pull you in, just as Many was suggesting, if they see a trend that they think is alarming, and get you in, give you extra insulin or whatever.
Yeah, exactly. I'm not sure to what extent they look at it between those appointment times, but in theory, they could check on it and call me in if they saw that there was a trend that they were worried about. Mm.
So you've been in 2 systems, though, haven't you? Health systems.
Yeah, so that's what I wanted to kind of move on to the next part of my background. The fact that I have access to these tools, living and working in Spain, is totally a privilege that's not lost on me. I grew up in the United States, where I was also lucky enough to have access to the education and the tools that I needed to care for myself. And I was also fortunate enough to have a mother who never took no for an answer, and taught me that a lot of the time you might have to fight for the newer tools or healthcare professionals that are actually listening to your concerns. But I know that's absolutely not the case for everyone. It's not the case for a lot of people in the United States, where socioeconomic status has a huge impact on the quality of care that you can actually access, and on the education you need to know how to self-manage. And I'm sure it's not the same in other cities in Spain or in other places in Europe. So I think that's something that is going to be a challenge as well, keeping the H2O project in mind, is how much variability of patient experience there is across countries.
And also that you shouldn't make assumptions about what level of health literacy and digital literacy a patient can have. I mean, we all know we've been surprised sometimes by our parents becoming, super avid silver surfers.
Yeah.
but other people are just not into it. So
exactly.
And also may not have broadband, or there are lots of other things that play into whether people can do these things.
Exactly. There's a lot to take into account in this project. And I think one of the biggest one is, does this person have access to the tools at all to provide digital outcomes, or to engage with their health in the new ways that we're promoting?
Yeah. How many of you found yourselves fighting for the broadband with your kids during lockdowns? Hands up if you did. Hands up if there was a broadband fight. Yep. I mean, that happens. You're all digital natives. So imagine what's going on in some households where maybe they only have a set of data allowance.
Right, exactly. We definitely have to keep that into account.
So how did you get involved in all of this?
So I guess when I was in my teens, I started really volunteering in advocacy work and patient writing. And the reason I got involved in that in the first place was because I was missing peer support. I didn't know anyone in person who had type 1 diabetes, and the information that was out there on the internet at the time was really quite grim. Just a lot of stories about all the awful things that might one day happen to me if I didn't take care of my condition. So I started writing just to kind of share my daily experience with type 1 diabetes, and there were other people as well at the time writing blogs. And it was kind of an outlet as well for the things that I felt weren't addressed in my medical appointments with my doctors. Sure, we had all the quantitative analysis and conversations that I could want about carb ratios, insulin needs. That was fine. But no one ever really asked about the emotional toll that living with chronic illness could have, not just on my daily life, but also then by extension on my ability to adequately self-manage the condition. At the time I was 16, the last thing I really wanted to do was hear that my behavior today might cause some problem in 20 or 30 years. I mean, you're scared, you're angry, you're sad. There's feelings of guilt too, a lot in
And
a
most
list like
teens
this.
just kind of double down on what a behavior it was that was the
Absolutely.
causing the issue.
I was not an easy teen.
None of us were easy teens.
No easy teens exist. But through writing that, I got that outlet, and I also found by talking to other patients that was a pretty common feeling, that we were going to our appointments, our checkups, and being told what to do, but not always discussing things that were actually relevant or important to us in our day-to-day lives, and not always being able to discuss the things that were truly impacting our ability to care for ourselves in the best way possible. So that's kind of how I got involved in advocacy, and then I think by extension, probably it's obvious why I got involved in H2O. When I saw the aim of the project, I said, sign me up. It sounds fantastic.
And so by this time, you had gone from being a teacher to actually being a software engineer. So actually, Seonaid, you are at this brilliant center of living with a condition, being a software engineer and having a view of the kind of the tech solutions, and this backstory of being an advocate, and realizing, just how these things that are really important to patients don't get measured. We tend to be obsessed, I guess, in medicine by, biomarkers and, other metrics, but we forget to say, how are you? How are you coping? What are the things that you really want to do in your life, and how can we make those possible?
Yeah, exactly. And I think that's what we've been working on a lot on the project, is defining what exactly those outcomes are that are important. And I'm really optimistic about the project. It's super challenging, super ambitious. But I think if we do start to collect this data, the data that is important to patients, that we can also start picking out those kind of pain points about, okay, what is actually stopping a person from having ideal health outcomes, and how can we intervene, and how can we help them?
So let's have a look at those pain points, because what we're going to do very much this morning and this afternoon is talk about implementing these digital solutions and what these pain points might be and how to resolve them. So where are the pain points for you as a patient, or as a person living with your condition, I should say? Because that's the other thing that we have to remember, is that people living with conditions don't like to be thought of as patients. They're people. They just happen to have whatever they have.
I think as a patient, and especially in the type 1 community, the biggest thing is that this is a disease that's 24 hours a day, 365 days a year. There's no vacation, there's no day off. So I think there's a sort of resistance to adopting new technology or new tools if we're not entirely convinced that it's actually going to relieve some of the daily responsibility that managing a condition like type 1
so it's
actually
got to be
entails.
Easy.
It has to be easy. It has to be usable. It has to be actually beneficial in the long run.
And it can't be buggy or have problems.
No bugs on the app. And
what are the other no-nos?
I actually, when I started software engineering, I ended up making my own application for myself, for the reason that I'd tried diabetes applications over the years and was always running into the same problems of like, okay, they're buggy. And then a lot of the time, they just had too much information that I didn't want to read and go through. I really needed it simplified. It's already a lot of time spent investing in your personal health every single day. So if an application is just going to give you 20 features that you don't actually need, it's not going to be a successful.
So it's got to be intuitive. So I'm guessing, this is maybe a terrible assumption, that you're not a person who wants to read the whole instruction manual before you just want to use it right out the box. You don't want to. How many people don't read instruction manuals? Yeah. My husband always reads the instruction manual before. I hate him for it. He's adorable, but I hate him for reading the instruction manuals. Because he always starts, you would have known that if only you'd read the instruction manual. Anyway, so it has to be intuitive. You need to get right in there immediately.
Yeah, it shouldn't be another responsibility on top of an already quite high number of responsibilities that people with chronic illness have every day.
And not too many questions. So you want the data to be, some of it to be collected kind of automatically without you having to do, a 60-line questionnaire at the end of each day.
That would be wonderful. If we can get a tech wizard to get that done, then yes.
Okay, what else for you? I guess you were hinting at this thing about the range of digital literacy that there is.
Yeah, so I'm not sure how the project will approach that, but there definitely needs to be something done about convincing patients who are probably resistant to using digital tools, to convince them that this is for their benefit in the end. And I'm not entirely sure how that's going to play out in the project. I'm kind of excited to see the talks that we're going to have here
this
today.
Is where it comes from local. It comes from the ground up. It comes from there being advocates amongst people living with certain conditions who get out there and say, this is really good.
Absolutely. There needs to be interaction with the people who are actually going to engage with and use these applications. And what I was saying to you before, I think it should be something that is not just designed once and done. No, it should be an iterative process. And throughout that entire process, we should be speaking with all of the patients who are affected.
And people should understand that you're fickle, by which I mean you will, if something else is offering more bells and whistles that suit you, then you're going to move over to them, and there is no loyalty.
There's no loyalty. No.
Yeah, that's a kind of important thing, because you can't rely on patient loyalty, and that has to be part of the business model that Manny was talking about, of having, people don't just stay because they're in a particular group. They want the things that work for them best, and they're prepared to move, providing it's easy to do with the data.
Exactly.
Okay, what else?
What else in the application? I think something that's going to be really important is trust, establishing trust between providers and patients. We were talking about before, it's not so much about privacy of our data, but it's about transparency. How is it going to be used? What is it going to be used for? How difficult is it going to be for me to find that information out? Like, is it going to be a 60-page agreement that I have to read to find out exactly how my data will be used? Or is there a simplified way that we can communicate that to patients that makes them feel they can trust the application that's being offered to them? So
it's a combination of both granularity and a big overview at the same time. In other words, you don't want to be asked 60 times a day whether you agree to have this or that use of data, but you want to be assured that there is someone looking out for you who's got your interests at heart.
Right, exactly. There should be someone working on behalf of patients to assure that the way this data is being used is ethical and in a way that the people who are going to be using these applications would agree with and support.
And I know this is particularly from my work in Genomics England, where we did a huge amount of public consultation, is there is a great concern about data that somebody's going to run off with it and make a fortune, and yet the patient is not going to be left better off. So that's a big concern.
That certainly is a big concern, and I've heard it among patient groups many times. I mean, it's kind of unsettling to know that on the one hand, of course, we benefit so much from all of the advances that pharmacy and technological companies have made. But on the other hand, it's quite strange to feel like your misfortune is probably the best business opportunity that these companies could ever have hoped for.
So the patients that I've worked with say it in this way. They say they don't mind companies making profit. That's not an issue. It's disproportionate profit. I think that's the kind of thing.
For sure. I think that's where there is a big point of worry. Yeah, are we doing this really for the greater good, which is what healthcare, in my personal opinion, should actually be about? Or is this just going to end up giving someone a ridiculous profit off of my data? Profit, as you said, is fine. But I know that there is that concern in the patient community of, what exactly is it being used for? To what end?
Okay, so it's funny, isn't it? Because everybody always says that privacy and security is top of mind, and very often it's the first thing that people say. But actually, it's what's the purpose that this data is being used for, and by who, that is the single most important question.
Yeah.
Okay, so we've talked a bit about trust and data governance. Another area, I guess, is about the range of conditions. So diabetes, I guess, is the poster child for self-management. And there are other chronic conditions. I mean, COPD is the one that I would think of immediately, or heart failure, perhaps. But what about other conditions, acute conditions? Where do you see the involvement of this kind of approach in those areas?
I don't have a lot of knowledge of acute conditions, of how this would be used exactly. No. But I imagine that acute conditions, would want applications that, with kind of the same guidelines as someone with chronic illness wants them, applications that are going to simplify the stressful period of their life that they're obviously going through when dealing with an acute condition.
And actually, virtual wards is something that are becoming more common in lots of countries. I mean, particularly during COVID. I mean, in fact, actually, COVID has been the great spur to so much of this, because we've realized that, I think we've realized not only that we can do it. I mean, look at home testing. Who thought? Everybody said nobody will do home testing. Stop it. People can't do home tests. I mean, it's extraordinary to think that women were not trusted to do pregnancy testing at home. That's the last 30 years, 40 years. I mean, and before that, it was toads. You do know that there were colonies of toads kept for pregnancy testing, and they didn't disappear until the 1960s. And after that, this lab in a box, and everybody said that won't work, and you can't trust patients, can't trust, because pregnant women were patients, thought of as patients then, not people, and how that's so radically changed. And now we know that there's so much that people are prepared to do at home and virtually, but they want to feel that they're embraced and that they're not kind of cut off somehow. So maybe there's a different kind of vibe that people need in an acute condition to a much more self-managed condition like diabetes.
Yeah, I think the number of tools that can empower patients are countless, and patients are willing to do a lot at home. And even in the case of type 1, I think another important aspect of this is we've come so far digitally. Like you said, at-home tests, virtual consultations. In all of that, though, I think it's also going to be very important to maintain some sense of feedback and communication between clinicians and patients. Although we now have all of these great digital tools, at the end of the day, I don't want my doctor to be my smartphone and that's it. No? So I think it'll also be important to integrate that as well, as much as we can, into the data collection and moving healthcare into the digital sphere, maintaining that human connection within it, because that is, at the end of the day, what we're looking for as patients, to be understood by our clinicians and to be given advice based on the things that actually matter to us.
So just finally to the thought about adoption, because there's one thing having a crowd of enthusiasts, and you're a crowd of extraordinary enthusiasts in this room, but how do you persuade the different parties to take up these things? So you'll always have the first adopters, but how do you then persuade other people?
That's the million-dollar question. I hope that with the first adopters, that the outcomes that we see from people who are enthusiastic and willing to try this out will be vital in convincing people who are maybe not totally on board. Obviously, right now it's going to be difficult. Not everyone wants to jump on the train immediately. I mean, every time I go to see my endocrinologist, she's sitting at her computer complaining that they've given her a new technological tool to master, and it's like, she doesn't want to do it anymore.
Yeah, and of course, all of this thing, depends on electronic health records.
Yeah.
And anyone who's ever been through onboarding an EHR in their hospital knows that it's hideous. I mean, it's so painful, and for at least a year, people just swear at their computers, and then after that, they won't have them taken away. So they're in love with them after a while, but it takes a while, and there is a bit of pain. So that pain period needs to be as short as possible, doesn't it?
Yeah.
So that people get into things straight away, they find it easy, but that there's a real benefit for them. And the benefit isn't just that they're in better health, because we all know, we've all had messages, don't smoke, eat more vegetables, take more exercise. And if we were just motivated by good health, we would not be drinking, smoking, or sitting in front of the television. We would be out doing those things, and we're not. So clearly, good health isn't enough of a motivation, even though lots of people think it ought to be. It actually isn't. So what can be the motivation? What do we need to give back to patients to persuade them?
I think time, honestly. The amount of time that's invested in managing a condition, in my case, like type 1, it's a lot. It requires a lot of cognitive management, organization, choice making. So anything, I think, that can be designed to give patients a greater sense of time, and in that same realm of freedom, is going to be worth it. It's going to encourage patients to adapt to new systems.
And what about community? Because I know you see patient communities. So in diabetes, the great online community for patients is DDoc in Europe, which is absolutely terrific. But how do you persuade people? Or I should say, is community a really important part of being what these things give to you? So if you're into running, you might do Strava or one of those kind of apps.
I guess that'll depend on each person, but I think, and each person in each phase that they might be in their life with chronic illness. I know when I was younger, I had a greater desire for community, and at certain parts when you're struggling more with your illness, you might need more community. But I think that's going to be an integral part as well, and also of being able to even see the outcomes or talk with people that have your condition within a similar health system. Maybe, for example, your doctor is suggesting you adopt a new glucose sensor system. I know that I would love to be able to speak with other patients, to be connected with other patients who had used that system and figure out what their experience had been. So I do think community will be a really big part of this as well.
Any final thought about adoption and is there any other incentive?
The incentive, which I think is asking a lot of patients, is an altruistic one of my data. One day will hopefully allow healthcare to advance even further than it already has. As you saw in the past 100 years, it's come so far. I know that for me, that's one of my motivations. That's one of my incentives, is to be able to give back and help contribute to health systems that actually really provide value to patients and give them a higher quality of life. That might not be the case for everyone, but I know that in my case, that's a huge part of wanting to participate in this project and to promote this project.
Seonaid, it's been such a pleasure having you with us.
Thank you.
Thank you so much.